Welcome to the Roetzel HealthLaw HotSpot. HealthLaw HotSpot is a podcast for physicians and health professionals that covers the legal issues and trends that affect the healthcare industry.
Hi, everyone. I'm Ericka Adler, shareholder and HealthLaw practice leader at Roetzel & Andrus. Thank you for joining us at the HealthLaw HotSpot. Today, we're going to be talking about alternative reimbursement models for medical practices. I'm really excited to have with us Dr. Eric Olmsted. And Eric is a health economist with over 20 years of experience working with health data for a variety of health analytic organizations. He's worked with a variety of health insurance data, including national payers like United and Aetna, regional payers like Blue Cross Blue Shield organizations, Medicare, and all payer claims data. Since the beginning of his career, he's used medical, pharmacy, dental, and vision claims to perform a variety of evaluations, including physician profiling and geographic health utilization analytics. So really excited to have Eric with us today. Welcome.
Thank you very much. Nice to be here with you.
So today we're going to be talking about alternative reimbursement models, and in particular, models that are tied to value-based care. And we throw this word around a lot, it comes up very often, but why don't we start with you from your perspective, explaining to everyone what really is value-based care?
So from my perspective, value-based care is changing the dynamics of how we currently pay for healthcare, which is based around the fee-for-service model where you go in to see the provider, they perform a service for you, and then the payer pays for every single service, whether that's an inpatient stay or whether that's going to see your doctor or an x-ray or a lab test. We're paying for all of those services individually. Value-based care is based on the concept that we should be paying for the value delivered. Ideally, we're paying for the improvement in healthcare that's actually being delivered from whatever services are provided. So instead of going in for a knee surgery and paying the doctor for the surgery itself and the hospital for the OR and the nurses and the services and supplies, we want to pay for, did that person's knee actually become improved? Are they able to walk on it now? Are they able to run on it? What gain of function have they gotten back from having that surgery? So value-based care in its ideal form is intended to improve and pay for how much health is actually delivered to patients. And we're a long ways away from actually delivering that kind of payment, but the two primary ways that we pay for value-based care in the current market are ACOs, accountable care organizations that people have heard about, and bundled payment. And both of them have their pluses and minuses, but for both of those, the real change in how the payment is rendered is that you're paying a provider directly for a set of services that are delivered to the patients rather than a particular service itself.
Right. So the idea, I guess, would be that we focus more on outcomes. So doctors are really getting paid for good results. But what about those patients? I mean, sometimes the best care possible doesn't always achieve a good result. So when when everybody's doing what they should do, but the result is not as great, is that kind of a knock against the fact that what they did had value or that it was quality? I mean, how can doctors kind of understand what's really going to happen to the type of reimbursement they might be receiving and not be afraid to just do the best job they can, but understand there's bad outcomes?
So it depends on the value-based model that you're looking at, but an example of not necessarily paying for bad outcomes is CMS is starting to not pay for readmissions. When you go to the hospital, typically, if you have one condition and then you come back with a related condition within 2 to 3 weeks, you get paid for that readmission. So you're actually paying for the first admission, then you're paying the hospital to say, not keep that patient out of the hospital. CMS is starting to create certain penalties around delivering care that will keep that patient out of coming back to the hospital. So that's an area where we want to stop actually paying for bad outcomes, because a lot of the cases with fee-for-service reimbursement is there's no alignment between whether the outcome is good or bad. You're going to get paid for it regardless. But in the more traditional sense of a value-based model, there's a lot of parameters built around how that model pays that are intended to protect providers against certain bad outcomes that they have no control over. So for example, in a bundle payment environment, they're establishing a price upfront that's kind of the average price for a knee surgery. So they're going to pay physicians the average all-in price for the knee surgery, including the surgery, the facility where the surgery takes place, and maybe even post-acute care that happens after the surgery. And they're going to give the physician direct control over all of that money. And the idea is, yes, there's going to be some outlier cases where somebody does have a bad outcome. Maybe they get a surgery infection and they have to be readmitted to the hospital. And the physician is on the hook for that. But overall, the physician has a lot more control over where all the money goes. An example would be they can choose the site of surgery. So traditionally, it costs about $10,000 to do a knee surgery in a hospital, whereas it costs about $5,000 to do the knee surgery in an ambulatory surgery center. And the reason it makes sense to pay the physician the full bundle is because the physician can choose whether to do it at the hospital or choose to do it at the ASC. But in the traditional fee-for-service environment, they're going to get paid $3,000 whether they do it at the ASC or they do it at the hospital. Now, with the $10,000 that they're getting paid on average, they can do all of their surgeries at the ambulatory surgery center, and then they get to keep the difference in that payment and still save money for the payer that was originally shelling out $10,000 for each knee surgery. So the idea is to give the control over certain healthcare decisions to a physician or other provider that's best situated to determine where the highest value care can be delivered. And so for knee surgery, it's not required to stay in a tertiary care center to get your knee surgery. That care can be delivered just as well in an ASC. It's typically the only reason a surgeon goes to the hospital is because they may have admitting privileges at that hospital and not have admitting privileges at an ASC, and haven't gotten admitting privileges at an ASC because why should they?
Right. So the hope is that some of this additional potential money that's out there gets passed on to the doctor for making these value-based decisions, whether that's really the way the physician contracts, employment agreements, or otherwise is set up will remain to be seen. But apparently that sounds like it's the intent. What other types of opportunities are out there for physicians in this value-based care environment? What do you see as those opportunities?
Well, there's a lot of opportunities for physicians in both the ACO environment and the bundle payment environment, precisely because physicians really do understand where the best care can be generated for their patients. And so they have a lot of control over those decisions. An example would be, I was working with Orthopedic Surgery Center in the bundle payment model for CMS. So CMS has offered the bundle payment for care improvement program since about 2014 to orthopedic groups and hospitals and other specialty providers where they can engage in these bundle payment programs. And we were working with an orthopedic group that changed how they practiced from in the first quarter of the program, and they were delivering all kinds of orthopedic surgeries, and they had an average length of stay of about 12 days in the skilled nursing facility for all of their patients. And when they changed to the bundle payment program, they started monitoring these patients. They had traditionally let the hospital decide where these patients should go. Should they go home for home health, or should they go to a skilled nursing facility? And they just let the hospital decide because they performed the surgery and they weren't really involved in that decision. In the bundle payment program, because they were getting reimbursed for choosing the optimal place of service, for post-acute care, they dropped those 12 average days of SNF care down to 4 days in the first quarter. And these people were getting home health, so it wasn't like they were, sacrificing the quality of the services that they were receiving. They were just looking at these patients and saying, there's no reason they have to go to a skilled nursing facility. And the truth is that most people would rather go to home and get, good nursing care in the home than have that services delivered in a skilled nursing facility where there's all kinds of downstream things that can happen to you once you're inside that kind of a facility.
That makes a lot of sense. So I would assume that kind of oversight of patient care applies not only to surgery, but chronic care conditions or chronic illnesses that patients have in terms of managing it, avoiding hospital visits, and overseeing their care as well. So I think what you're saying is that's just an example. And these same types of decision-making opportunities are being looked at across the board to kind of find out where doctors themselves can make decisions that improve value and quality for patients, but also can save money for some parties and make money for other parties. Is that kind of a good little summary of where we stand on it?
Yeah, I think I've talked a lot about more acute conditions and the opportunities that exist in acute care, but there's a lot of opportunities that exist in the chronic care space. And in the chronic care space, there aren't really differences between bundle payment and accountable care. At the end of the day, they both focus on managing the patient with a chronic condition. And I think that the change in the mindset in that area of practice is kind of going from a reactive approach to healthcare where patients are coming to you and they're coming with a particular problem that they want, you to treat, and that might be a symptom rather than the underlying disease itself. More frequently, I think patients come with symptoms. In a value-based environment, you really want to be more proactive and start looking at your entire patient panel and figure out who are those chronic members, what you can do for them. In a lot of cases, dealing with chronic patients is more about getting them to change certain lifestyle behaviors, getting them more adherent with their medications, getting them to come in more regularly to see the physician and make sure that any symptoms are being addressed, rather than waiting for the patient to come to you. And in a fee-for-service environment, there has been no reimbursement mechanism to give physicians the time and kind of space to think that they need to actually manage those chronic populations, because they need to churn through patients in order to get that fee-for-service revenue in order to support their own practice. So in order to stay alive and stay really financially eligible as a physician, you have to work under the constraints that you've been given, which is the fee-for-service environment. The design behind an ACO and bundle payment for chronic conditions is to give physicians additional ways to get reimbursed by managing those patients better than they have been managed in the fee-for-service environment. And I can see in the data, we already know, it's well known that they're not getting optimal care because of this tendency to churn and get people in and out quickly and not give physicians the space they need to really do that kind of critical thinking for their patients.
Right. And, from my perspective, and I think that I'm a healthcare lawyer that deals with a lot of independent practices, and I work on a lot of their contracts. And I'm really not seeing the type of changes in their contracts that you're describing as a change in the environment and the reimbursement approach. So a lot of doctors are still either being paid for their personal RVUs, their personal collection, or their salary, okay? And we're really not seeing a change. There are some doctors, particularly hospital-employed ones, and sometimes private practice, where there's a potential to earn a bonus based on meeting certain value-based care. That might mean completing patient questionnaires, or it might be closing records in a certain amount of time. But nothing that really has to do with decision-making about how they're handling their patients or where they're spending them or following up on chronic care. I'm really not seeing that trickling down to the actual contract level. Even within physician practices, and I work with a lot of orthopedic groups, I would imagine that those decisions about where a patient's going to recover and how they're going to meet the requirements of an ACO or other plan are being made at the management level, not really at the doctor level, although who knows, maybe they're asking for doctor input. So it's really interesting because we have all this data and, looking at it, how can we have cost savings? How can we better help patients? But I'll be looking to see it kind of trickle down to letting any of that decision-making be done by doctors and letting any of that cost savings really be, enjoyed by the doctors, or any of the better outcome money enjoyed by the doctors. So I'm really looking at it from the other side. I'm not seeing as much of that as it sounds like we might down the road.
I think that's a really important point. I think especially in the primary care environment, one of the things that's happened is even as commercial payers have gotten engaged, especially with ACO style programs, hospitals have reacted in a very different way in that they've acquired a lot of physicians. Either they've acquired those physicians and are directly employing those physicians, or they're creating physician hospital organizations, and the ACO is based out of a physician hospital organization. And what happens is the hospital takes control of the ACO contract itself. And frequently what happens in that scenario is you end up with a hospital that's more interested in decreasing leakage. They want to make sure that the patients that are in their ACO network are actually sending those patients to their hospitals rather than focusing on, again, the accountable care style improvement in chronic treatment with less known reimbursement to the hospital. And that's the issue is at the end of the day, a lot of these value-based arrangements are going to take money away from the hospital because that's where a lot of the money is going now. So if we're going to reduce spend, we have to reduce spend in the hospital system. There's not a lot of other low-hanging fruit out there. There's some post-acute spend that is being worked on in the Medicare space, but in the commercial world, if you're younger patients, it's all in the hospital. And so as long as the hospitals are controlling those contracts, that's going to kind of reduce the impact of accountable care, especially in the primary care market. And unfortunately, I don't have a good solution for that from where I sit. Maybe you do.
I think, the overhaul of healthcare in this country is part of that. We have, doctors who are getting squeezed more and more. And I'd like to see some of that come to them. And we're going to have to be seeing some changes in how healthcare works in this country, which kind of leads me to my next question. You and I have kind of talked about it, but we're seeing, we saw direct contracting start to become more of a trend. And I know that you're really excited about this topic and kind of want you to explain what that is and what you see as the future of direct contracting in the healthcare environment.
So direct contracting is, it's a similar approach to value-based care, except for the value-based care programs that we've talked about so far, ACOs and bundled payment, are all led by the payer. So this is the health insurance companies. This is primarily CMS with the CMMI, the Center for Medicare and Medicaid Innovation, that have actually been leading the charge in value-based payment. The commercial payers are kind of lagging behind, although they are establishing ACO contracts. But direct contracting is actually working on arrangements between employers and providers themselves. And I think this is exciting because you're not as reliant on those payers to be progressive and to start thinking about new ways to change payment. And payers aren't always as incentivized to reduce healthcare spend as employers are. For employers, healthcare spend is just coming directly off their bottom line. It's just a straight cost. It's not something that they know a lot about. And so a lot of what they do is outsource the whole thing to, the payers, trying to take that problem away from them. It's not a focus of their core business, but it is 20% or more of their total costs can be tied up in healthcare. And the great thing about direct contracting is you can actually cut out the payers and work as a provider directly with local employers to start delivering care. And we've seen this a little bit in the primary care space with concierge medicine or direct primary care. And that has been growing pretty well, I think, across the country. There's a lot of large employer groups that are putting primary care practices directly on some of their facilities. But it can work outside of the kind of facility-based or clinic-based approach as well. If you're a primary care practice, there are employers probably in your market that are open to at least a discussion. And another area where I'm starting to see a lot more growth is in surgery-based kind of episodic payment that's direct contracting. So this is the same concept as bundle payment working with a payer, except for it's a direct contract between an employer or frequently a set of employers and a set of providers. And there are two general styles. There's a lot of centers of excellence. So you hear the Geisinger clinics, some of the large Cleveland clinics, some of the larger health systems out there are directly contracting with different business groups to do surgery for cardiovascular, orthopedics, and gastroenterology, and bring patients from all across the country when these are nationally based employers to their clinics, and they have a predefined price for the whole thing, and it's so much cheaper than what the payer is spending that they actually carve it directly out of their insurance, and the employer is paying those clinics directly. For smaller practices, you're starting to see some businesses that are actually moving, especially ambulatory surgery centers that are moving directly towards direct contracting with regional businesses or local businesses. The Oklahoma Surgery Center is a great example of this, where they literally post their prices for surgeries directly on their website. And they just tell anyone, if you can get your employer to pay for this, if you want to pay for this, this is our price, and we're going to do a knee surgery all in for this amount of money. And it's something that any practice can do. There's nobody to stop you from doing that. I don't know about all the legal ramifications, but there's no payer that needs to get involved with it in order for you to set that up.
I think that's exciting. I definitely think that's a trend that we're going to see growing. It doesn't work for every employer. They have to be able to afford it, obviously. And not everybody's as forward thinking. As great as these new value models are, there's a lot of people still stuck in kind of how things have always been, and are really unable to think outside those normal parameters. And unfortunately, it's going to take, I think, a bit of time to everybody. Taking concierge has been around for quite a long time, and there's still just a small amount of it, really, relatively speaking, going on. But before, it was really more who could afford it, right? It was kind of like, you still have to have insurance, but you could pay extra money out of your pocket for these extra services. And there definitely are some legal issues involved. So this seems like the next step, really broader, more sophisticated. And I think it's exciting because unless people start trying to do some new things in healthcare, we're not going to see kind of changes. And we're just going to keep complaining about all the things that are wrong with it. And yet, nothing is going to improve if we don't try out some new opportunities. I guess, I can see that you're pretty excited about these alternative payment models. Is there anything else you want to bring up to kind of wrap things up on this topic?
Well, I think just to talk a little bit about who can afford these, direct contracting arrangements. The great thing for employers, a lot of employers are what we call self-funded, and that means that they actually cover the cost of the claims, and they're using the insurance companies as really just a way to have a network of physicians that people can go see, and the employer is still on the hook for all of the costs of whatever surgeries they're doing. And in those scenarios, those employers are going to see savings because the cost, for instance, when we talk about the Oklahoma Surgery Center, they're talking about a knee surgery for like $3,500 when the typical cost is $10,000, and that's going to go directly to the employer. So the great thing about direct contracting, and the trick with direct contracting, I would say, is to actually analyze, for employers to actually take a look at their own costs and see what they're paying for these services, and then compare it to somebody like the Oklahoma Surgery Center, or talk to their local providers about how much less they could actually spend for these services, because the differences are extraordinary. And one exciting development is kind of this price transparency piece that's coming out from CMS. Now, there are groups that are just starting to get around this data, and it's not perfect, and some of the payers are kind of lagging their feet, taking a little while to produce this data, but it's starting to show the huge variation in cost that exists for literally the same service, the same CPT code within an individual market. And that's going to open up the opportunity for these employers to say, wait, why am I paying through United $10,000 for this when this other group is getting the same exact service for $3,500? And they can actually go to those providers and say, would you give me, this price? And so I think price transparency is really going to open this up for both the employers and the physician practitioners to kind of expand these contracts.
I think that sounds great. I'm hopeful that'll be the case. How long do you think it'll be till we really start seeing these kind of models becoming more prevalent? Are we really talking a year or two? Are we talking 5 years, 10 years? Changes in healthcare take a long time.
Well, I think they're starting to become more prevalent now. There are organizations out there that are really trying to build marketplaces between practitioners and employers. And I think there's the self-funded employer network. I can't remember what it's called, but I can send you a link. But there's an organization of self-funded employers, and they're starting to look at these direct contracting and, again, try to build that marketplace between the physicians and the employers to develop these kinds of arrangements. And I think it's really just creating that information flow that's going to speed this along. And at some point, the payers are going to have to react as well. If enough of their business is starting to get carved out with these arrangements, you're going to see some pressure put on the payers to actually take control of this process and start doing some of this themselves, And I think that's when you're going to see faster change. I think it's just starting to happen now, but I do think that the price transparency, the fact that it's starting to get talked about by brokers and consultants for these employers, and employers themselves are talking about it, as more of these arrangements come online, the payers are going to react, and then you're going to really see changes and more opportunities for physicians.
Oh, that sounds
But I also think physicians can get in on this themselves by, just taking a look at organizations that are out there that are trying to create these markets.
I think that's great advice. All right, so before we wrap up, any final thoughts you want to share?
No, I just appreciate you having me on. It's been great talking with you. I'm always excited to talk about healthcare and how to use data and analytics to change how we deliver healthcare. It's kind of a passion.
Well, it's been great to have you here. So we want to thank Dr. Olmsted for joining us. And this has been the HealthLaw Hotspot. If you want to see more of our episodes or find out more about Roetzel, you can go to ralaw.com. Thanks for joining us.
Roetzel HealthLaw Hotspot is made available by the firm and its attorneys for educational purposes and to provide general information, not to provide specific legal advice. Use of the Roetzel HealthLaw Hotspot does not create an attorney-client relationship between you and the firm or any of its attorneys. The Roetzel HealthLaw Hotspot should not be used as a substitute for competent legal advice, and you should contact an attorney in your state about any legal needs or questions you may have.